Parkinson's in Minnesota is a co-production of Mayo Clinic and Twin Cities Public Television.
Our topic for this program is Parkinson's disease. It's a disorder of the nervous system that causes problem with muscle movement. We're going to delve into the disease, talk about treatment options, promising research, and places you can go to find out more information. But first, we want to go over the basics. Here to help us do that is Dr. Jim Maraganore, a neurologist with expertise in Parkinson's genetic research at Mayo Clinic. Welcome, doctor. Thanks for coming. First, let's talk about how prevalent this disease is.
Yes, well, you know, it depends on what population you study, but if you were to go and knock door to door in a given population, and if you focused on people above the age of 55, about 3 or 4 people per 1,000 individuals would actually have Parkinson's disease at any one given time. Or to put it in another way of thinking about this, all of us are born with about a 2% likelihood of developing Parkinson's in our life. So it's not the most common disease, but it certainly is common. About 1 million Americans is the estimate that you'll oftentimes hear presently.
It was interesting that you broke down that initial number by age, too, because we tend to think of it as a little bit of an older disease, but not always, right?
Exactly. I mean, typically, if you, for example, looked at a large series of patients that we've been studying at Mayo Clinic, the average age that people would first develop symptoms is about 67, 68, so just after retirement. But we'll see many patients who will develop the first symptoms even in their 50s, 40s, 30s, and rarely even younger.
Wow, and the symptoms are?
The symptoms are typically slowness of movement, Greek word bradykinesia. We will also see patients complaining of a tremor, typically occurring when they're at rest. Patients are oftentimes unsteady and imbalanced, although that's typically a later sign of the disease. And then patients will oftentimes have stiffness, although they may not complain of that. That may be something that the doctors will detect on examination.
And how frequent would those symptoms be? Because I think many of us have had some of those symptoms any time of your life.
Well, it's the constellation of those symptoms together that really adds up to a diagnosis of Parkinsonism, or more specifically, Parkinson's disease.
And are there some you talked about some of the early symptoms, but, you know, are tremors typically later on, onset? Are there things that people could look for early on?
It's very variable. You know, some patients will recall sitting on the couch and being excited about a football game, the Gophers losing again, perhaps. I went to Northwestern, so I can't tease about the Gophers too much.
Yeah, watch out, you're talking to a Gopher.
Yeah, and, you know, and they might have noticed that one of their thumbs started to shake a little bit. It could be something as simple as that, or they might notice that when they write, when they sign a check, that their handwriting tends to get smaller across the page, or a loved one might notice that when they're walking, they might say, hey, swing your right arm. Why aren't you swinging your arm any longer? So it could be something as subtle as that. But it's the adding up of these symptoms, the slowness, the stiffness, the resting tremor, that leads ultimately to seeing the doctor and making the diagnosis.
The symptoms sound kind of difficult to diagnose, and I was fascinated to read that you can't confirm this with a blood or a lab test. So how do you confirm somebody has Parkinson's?
Well, you just have to see a qualified physician who is aware of the symptoms and of the signs. When a well-versed physician examines the patient, about 90% of the time, or better, I would expect better, but about 90% of the time we're correct about the diagnosis just by observing the symptoms and the signs of the disease.
Wow. And finally, we'll talk about this much throughout the show, but what is going on in research? What can be done for treatment?
Well, you know, I think that we're making great strides. The goal of research for Parkinson's disease is simple. We want to predict who's going to get Parkinson's disease, we want to prevent it from happening, and we want to halt it when patients fall through the cracks. And we're making great progress in all regards. I think that we're getting very close to developing methods of predicting Parkinson's disease by looking at complex DNA fingerprints. We're learning about the basic causes of diseases in rare and unusual families, and that's giving us major clues about therapies that might slow or halt the progression of the disease.
And thanks, we'll hear from you more later, Doctor.
Absolutely, thank you.
A recent Frontline special explored Parkinson's disease through the eyes of one family. Dave Iverson is a television producer who was recently diagnosed with PD. His father died of the disease. He also has a brother with Parkinson's. Here's a bit of Dave's story.
My father was a man with an easy smile. and a ready wit. And to his great good fortune, he had quite a partner at his side. My now 96-year-old mother, Adelaide.
It's such a natural picture, really.
Yeah, well, I don't think he would have been posing like that.
Well, who knows? You remember he was the Lone Ranger once.
My father was a performer at heart, and my parents married not long after he'd finished a stint in radio, working on the original Lone Ranger.
I love this letter from his broadcasting company.
Oh, this is a wonderful letter. Read it.
It's with regret that we learn that Bill is considering the completion of his course, as he has a fine voice, good vocabulary, and an instantaneous mind. I always love that phrase, an instantaneous mind.
My dad left broadcasting to become a teacher, but the spoken word remained central to who he was. Language was his gift, a gift that began slipping away in the fall of 1971.
I was walking with him, and I thought he was holding his hand, just not in an ordinary way. It looked stiff and different.
It was the first sign of Parkinson's, a condition that not only steals movement, it can rob you of something more.
He was mostly concerned about his voice because he did have a good voice. And that deteriorated gradually. Toward the end, he really couldn't talk.
Dave Iverson's family struggle with Parkinson's is not common. Most Parkinson's patients don't have relatives who also have the disease, but there is much ongoing research trying to find the genetic role in Parkinson's. The Mayo Clinic has been studying PD and genetics for more than half a century. Here to talk more about that, again, is Dr. Mariganore. Also with us is Dr. Paul Tuitt. He's the head of the U of M's Movement Disorders Clinic. And we're joined on the telephone from San Francisco by Frontline documentary producer Dave Iverson. Dave, are you there?
I'm here, Mary. Thank you.
Hi, Dave. You know, really stirring story that we just saw in the Frontline documentary. Tell us how your symptoms first emerged. We were just talking about symptoms being, difficult to diagnose at the beginning.
Well, it was interesting because as I was hearing Dr. Mariganore explain the symptoms, I was thinking about the fact that in my family, all of those things have been experienced, but each of us in somewhat different ways. Michael J. Fox likes to say that everyone gets their own individualized version of Parkinson's, but unfortunately none of them come with operating instructions. And that's really the truth. My dad had sort of a stiff side and held his arm awkwardly. My older brother, Peter, who also was diagnosed with Parkinson's, has a tremor. For me, it was that my arm didn't swing that I noticed when I went out jogging. So it really can be any of those things. And for me, it was very small. I just sort of noticed this one day when I was jogging, noticed a sort of odd sensation in my leg as well over time. And I probably wouldn't have thought anything of it except for my family story. So my antenna was sort of up. But for lots of people, as your experts and physicians can attest, it's a slow, subtle disease, and it often doesn't show itself for some period of time.
Dr. Tuitt, here we have a case of, is this a genetic disease or not? Dave Iverson, 3 people in his family. What do we know?
Well, what we do know that when you have several members in the family with Parkinson's, and in your case, Dave, a parent, there's a greater chance that there's a genetic factor, and that's why the work at Mayo and elsewhere is very important. That we are finding genetic factors, causative genes that increase the risk of Parkinson's. The founder of Google, Sergey Brin, his mother has a gene abnormality that he also carries, and that's another story that we'll have to see is will Mr. Brin develop Parkinson's? Having a gene doesn't mean you will get a disease. So that's where the genetics and environment has to be sorted out further. But now we have names of genes, we have genetic factors. The work that Dr. Mariganore has been doing is, leading the way.
And Dr. Mariganore, tell us about your research too, and this family link or not family link, yeah.
Well, I've been studying the genetics of Parkinson's disease for about 20 years now, and And I started when really it wasn't very fashionable to study genetics. Everyone thought that the disease was primarily due to environmental factors. You know, we heard about Dr. Langston on the program and the very exciting discoveries he made in the 80s, and those were largely the reasons I decided to become a Parkinson's specialist. It was such a romantic and exciting time in our field. But when I went to England to do some finishing school, I had a mentor who said, you know, there are a lot of families still in which many members have Parkinson's disease, and we should take another look at these families and using some more modern ideas about what might be causing Parkinson's in these families. And indeed, about 15% of patients with Parkinson's disease will have a family member, report a family member with the disease. And if you look in the first-degree relatives of Parkinson patients as compared to the first-degree relatives of people without Parkinson's, there's about a doubling in the risk for Parkinson's disease. So in most instances, Parkinson's disease is not due to a single genetic cause, but in rare instances it can be. The question is, what's causing the disease in the vast majority of patients? To what extent is it genetic? And the conventional wisdom has been, well, Parkinson's disease, except for these rare families, isn't genetic. But we're starting to change the conventional wisdom, and we've made some new discoveries that are challenging that thinking.
Why don't you pick up on that and challenging the thinking and the genetic discoveries, because you are kind of mapping the genes and can identify them now, right?
That's right.
Yeah.
But if, you know, the average age of onset of Parkinson's is 58, 59, 60. When someone comes in, they may ask, is there a test? Well, presently we aren't doing genetic testing. We are interested in trying to understand it better. At some point we may collect DNA for research purposes and those individuals without a family history, and we may find ultimately genetic factors. It's though the clustering within a family gives you more evidence. And certain ethnic groups clearly have higher association with different genes. North African Berbers, some Ashkenazi Jewish families have genetic changes, various other collections of ethnicities.
I'd like to bring Dave Iverson on the phone back in this. Dave, I'm wondering, the question of genetic testing, is that something you considered, would want your offspring to consider? What are your thoughts about that?
No, it's a fascinating question, and it's one that I think we'll be facing with a great deal more frequency in the future. I mean, as I understand it at least, the purpose of taking a genetic test would be to assess the risk that you have and then whether or not there's something you can do about it. The problem right now is that you can determine, as Sergey Brin has, that he carries the particular gene, but there's not necessarily a lot you can do with that information. My daughter, my nephew and nieces are all aware that there's maybe something going on in the Iverson family gene pool, and that they are perhaps at some additional risk, as has already been described. But they're actually not that eager to necessarily know more than that, because there's not necessarily a lot that you can do about that, other than, of course, lead a healthy life and exercise and all the rest of those things that we can all do. I think the exciting thing about this, though, in time will be that they will be able to detect whether or not someone has the propensity to get the disease. And if they can figure out, if people like Dr. Marajanori can figure out a fix for that, then in essence you have a ready-made target for the disease. You can hone in on it, and you could stop it, in essence, before it even starts. So in time, for someone like my daughter, that'll be hugely beneficial. We're just not quite there yet.
Okay, thank you, Dave. I think you set up perfectly, Dr. Marajanori, and the benefit of genetic testing, maybe not yet, but down the road, how close are we?
Well, I think that there are benefits even today. And let me give you a couple of examples. There are certain genes or certain gene mutations that we know cause familial forms of Parkinson's disease. And if you have certain mutations, your disease will progress in certain ways. So, for example, some mutations may carry, unfortunately, a greater risk for dementia and impairment in mental faculties. And a person with that type of mutation might like to know that information to plan ahead for their future. But more importantly, I think that there are some mechanisms that we already can attack. So, for example, we started studying about 80-plus years ago an Iowan family at the Mayo Clinic. It was studied by 5 generations of neurologists. I was generation 4. And unfortunately, 5 generations of family members came to the Mayo Clinic for care. And in the early 90s, we started the genetic study of this family, and we discovered that having too many copies of the alpha-synuclein gene was the cause of Parkinson's in that family. We now have a therapy that we're developing to reduce alpha-synuclein. So if you had a genetic test and you knew that you were making too much alpha-synuclein, you could receive this therapy or similar therapies, and it could even be curative.
Fascinating. Thank you so much, doctors. We're out of time for this segment. And Dave Iverson from San Francisco on the phone. Dave, wonderful work, and thank you for joining us as well.
Sure.
Thanks. One promising area of treatment for Parkinson's disease is deep brain stimulation, or DBS. It's been called a pacemaker for the brain, and here's basically how it works. A device is implanted near the collarbone. It stimulates the brain with small electrical signals. The stimulation can bring about rapid improvement in controlling tremors and other neurological symptoms. DBS was developed in Europe and was first performed in the United States at Mayo Clinic in 1997. Now I want to spend a few minutes talking about how DBS works. Dr. Paul Tuitt is back. He works with DBS at the U of M, and here with us as well is Dr. Kendall Lee, a neurosurgeon who performs deep brain stimulation at Mayo Clinic in Rochester. First, Dr. Lee, let's talk about this technology. How new is it? How risky is it? How wonderful is it?
Yes, well, as you just pointed out, that the surgery happened in the United States in 1997, but it was originally performed by a neurosurgeon in France. It involves placing a stimulating wire into deep part of the brain. That's why it's called deep brain stimulation. And in the case of Parkinson's disease, the areas that we stimulate now include an area called the subthalamic nucleus, or STN, and GPI, or globus pallidus interna.
A lot of acronyms here.
Yes, that's true.
Yeah.
But basically, these are areas of the brain that's been identified to be involved in the circuitry that's involved in movement. And so the way that we believe it works is that these stimulation affects this circuitry so that our patients can move better. And actually, there's extraordinary amount of research that's been done to understand better how this is working.
Dr. Tuitt, take us inside the operating room a little bit. Are patients awake? When do you see it, the progress? Tell us how it works.
Well, I'm not the surgeon. Dr. Lee is the surgeon, but from my perspective as a neurologist, the patients are in how we proceed with surgery. And actually, we did the first STN case, or GPI case, in Minnesota in '96. So we had one of the first clinical trials starting in. But nonetheless, the surgery is done. The first part of the surgery, patient is awake, and that's an important part of the surgery where the surgeon's mapping out the brain's electricity and using MRIs preoperatively to know exactly where they're going surgically. And as they pass the electrode through the brain, they're recording brain cell activity. It's sort of been described as traveling through various countries in Europe. You hear different electrical signals, just as you would hear different languages, and then lets the surgeon know and the physiologist know where they are. So once they reach the appropriate target, they remove the recording electrode and put in a permanent electrode, which is now made by Medtronic. There's a pacemaker that's subsequently put in a follow-up surgery, or sometimes the surgeon does it at the same time. But it's an arduous process for the patient because they're awake and they have a frame on their head, and it has its risks. So people are always a little scared. But it's a very precise surgery now. They have excellent frames to help that proceed. And I'm sure Dr. Lee could comment further.
Yeah, improvement, is it immediate, dramatic? How much does that vary?
Yes, actually, I'm very excited about this surgery because the improvement we see can be at the time of surgery. And so, as it was mentioned, this surgery is done with the patient awake. That's very important because of the electrophysiology we have to do, mapping out the brain, but also during the surgery, we stimulate the patient so that we can see right then and there whether or not this is effective or not.
So a
for the
tremor could
patient.
stop right
yes,
there.
Yes, absolutely.
You've
and in
seen
fact,
that happen. That's remarkable.
when I first started to do this operation about 10 years ago, that was the thing that really excited me the most, which is right at the time of the surgery, the patient would come into the operating room with the tremor that is characteristic of Parkinson's disease. But as soon as you turn on the stimulation, just like that, you can see the tremor stop.
Wow, and it's lasting?
Yes, and now we have reports that's been published in very powerful medical journals, such as the New England Journal of Medicine and Journal of American Medical Association, which demonstrates that this is long-lasting for many, many years.
Dr. Tuitt, why would this be better than medicine or do things that medicine can't? Because deep brain surgery sounds scary.
Yeah, it's not for everyone, and I would say 10 to 20, maybe 30% of patients do end up seeking surgery for problems that medicines don't adequately treat. There's some patients that come in with prominent tremor, and despite medications, their tremor persists. So early on, within even the first few years of Parkinson's, they may come to their surgeon to get treatment of tremor. Michael J. Fox had a different type of surgery. He had a lesion type surgery, but he got surgery for his tremor began in his left pinky. So it hasn't treated some of the manifestations that are seen in his video clip, the dyskinesias. And those are the things why many patients come to surgery. The medicines have led, and their disease have led to involuntary movements, insufficient benefit in motor function. I mean, there are a variety of symptoms that the person may experience that they want treated. So that's why talking with your physician, trying to review those symptoms you have to see if you're appropriate candidate.
I said as a layperson this sounds scary, and I'm definitely the layperson here, but what are the risks?
Yes, certainly. Well, because this is a brain operation and it involves an electrode being implanted into the brain, the risks can include hemorrhage, stroke, as well as, but the one that occurs most often would be something like infection. The infection rate, depending on the publication, is anywhere between 2 to perhaps 10, 15%. But for the most part, what is also exciting about this, though, is those patients that have had infection, after the removal and treatment of the antibiotic, most of the patients ask for the reimplantation because they enjoy the benefit that they got while they had the stimulator.
We heard Dr. Tuitt say maybe this is 20% of patients it's effective for. Is that number going to change in the future? Do you think that's where you're headed?
Well, what the most recent publications are showing is that perhaps that more patients could benefit than the 10 to 20% that we know of now. So, for example, another benefit from surgery is that some of our patients are actually able to decrease the medications that they're taking, and in some, they can actually come off of medication, although that's usually less common. But most commonly, unless you decrease the medication, some of the patients might have too much movement, what we call dyskinesia. So it's very important that the surgery gets coordinated with the neurologist and the medication so that the two type of therapy can be coordinated very well.
And how do you see those, again, heading into the future, the percentages?
Well,
And
Minnesota has about 15,000 individuals with Parkinson's. It will soon be 30,000. So we'll have, and you can calculate based on numbers, 10%, 20%, even maybe 40%. A large number of patients that are going to need management of their symptoms with either medications and or surgery. Surgery is fantastic, and I'm a great proponent of surgery. It doesn't treat all the problems that patients have with Parkinson's. So we have to be honest about what, in those discussions with patients, is what it will help and what it won't help.
What won't it help?
Well, if you have memory problems, if you have significant memory impairment, dementia, it won't help that. May not improve speech or swallowing difficulties. Balance may not affect if the person's following, it may or may not correct that. So it has to be carefully evaluated, and most neurosurgeons like Dr. Lee, who's also a neurologist, which I learned, the ones that are doing functional neurosurgery, I think have been superbly trained and they understand the nuances of Parkinson's. And so they're working with a team of neurologists at Mayo, at Minnesota, elsewhere, to make sure that all those issues are carefully addressed.
And quickly, before we're out of time here, just more broadly, deep brain stimulation can benefit things besides Parkinson's, too. Isn't this kind of an expanding arena of medicine?
It certainly is. And in fact, now studies are currently underway for DBS for treatment of depression, obsessive-compulsive disorder, epilepsy, and even obesity. So it's very exciting what's happening.
We're still learning a lot about the brain, aren't we, as we go? Thank you so much. Now, we want to make sure that if you have questions here in Minnesota about Parkinson's disease and about treatment options, that you have somewhere to get your questions answered. Here are some web addresses for you. The National Parkinson Foundation has a comprehensive website at parkinson.org. The American Parkinson Disease Association has many resources at apdaparkinson.org. Again, that's apdaparkinson.org. And the Parkinson's Disease Foundation maintains a site you can find at pdf.org. Again, pdf.org. Now, we'll give out these web addresses later in the program. Now we want to spend some time during this program hearing from a family that has had to deal with Parkinson's. We want to stay right at the top here that every patient's experience with Parkinson's is different. Tim Skoglund and his wife Artis have been coping with Tim's PD for about 6 years now. At first, Tim was able to treat his Parkinson's with medication alone. Last year, he underwent deep brain stimulation surgery at Mayo. Along with him every step of the way has been his wife Artis. Dr. Kendall Lee is Tim's neurosurgeon, and we've asked him to sit in on the conversation, too. Tim, we'd love to start with you and thinking back to some of those early symptoms and maybe even symptoms that you missed now looking back.
Yeah, well, the one I think I missed was the sense of smell. I mean, I knew it was gone, but I didn't think ever anything of it. I probably lost that 5 years or more before I was diagnosed.
Well, so that's quite some time. And was it just completely gone? Was it sudden or gradual? What do you recall?
I don't think it was overnight.
Okay,
but it was
pretty quickly, it sounds like.
Within a couple of years, it was all gone.
Okay, and then what were some of the more obvious symptoms that probably got you into the doctor asking questions?
I had trouble getting in and out of the car. And when I walked, I'd carry my right arm like this, and my left arm didn't swing. And I was visiting a general practitioner for a bad cold, and she picked up on some of them too. So,
Artis, how much did you notice? Were you, often wives, I know how I am, harassing the husband about, hey, you need to get this checked out. What were your early concerns?
I think I noticed the slowness. I didn't understand it, and that was part that was very frustrating. But everything became a big deal. I also noticed the gait, where the one foot was dragging, and of course I saw the hands too, but the gait was very noticeable. Like there's something not right here.
And what age were you diagnosed, and was really the onset of this?
I was 51.
51. So let's go to the doctor here. That sounds pretty much in the normal, predictable,
Yes.
Maybe a tad young.
No, I think that's
pretty predictable.
Yes, that's right.
That's when we see it. And again, when people come in, I think this is one of the fascinating things. The symptoms do sound very subtle. You have to kind of put them all together.
Yes, and so sometimes, like Dr. Maraganori was saying earlier, that sometimes patients might see tremor start. And initially, this can be confusing because there are other reasons for having tremor, such as essential tremor, which is, by the way, also treated by deep brain stimulation. And that's why it's very important that the patient see a trained neurologist in movement disorders so that an accurate diagnosis can be obtained.
Because, Tim, a tremor was not your main issue. That you didn't have that early on, is that right?
No, and I've never really had
never
it.
Had it.
Not a major one.
Huh.
I mean, sometimes, if a neurologist looks at my little finger, they'll see a little bit. But not that people would notice.
So the variety of conditions and symptoms just sounds astronomically difficult, too, because we all have that stereotype. It's the tremor disease, right?
Yes, that's right.
It's much more complicated than that.
That's right.
And How about what has worked and what hasn't worked? It sounds like you had medication early on. Tell me about how that worked.
Yeah, well, I started taking medicine right after I was diagnosed. And they say that's the proof when the medicine works. And I had a tremendous reaction to it. A half hour after I took the first one, we went for a walk, and my right arm, instead of here, it went down, but it didn't swing. My left arm started to swing. I went to work, and I could move the mouse on the computer a lot better. You listen to my greeting on my voicemail. I was talking much faster. I'm sure my wife saw a lot of things, too. There was just a huge...
Your handwriting size increased.
So, yeah, just before I was diagnosed, one thing that really, made me realize something was wrong was my handwriting probably shrunk to about half the height it was at before. So.
And it went back to normal. What else did you see? The medicine sounds like it was an early breakthrough for you.
That the movement was definitely an improvement, and also life was bearable again. I mean, everything that had been so traumatic was now taken in stride.
And can you talk a little bit more about that? Because you say everything that's so traumatic. What is it like living day to day with this?
Little things, the kind of paranoias almost of, things that were a normal easy decision now is we have to weigh this and think about this and, factor a lot more things in. And when you realize it's the disease, then you approach it and deal with it differently. But not knowing that was challenging. Okay. And the medication certainly has helped that. And the deep brain has made a big difference there, too.
Let's move on to that.
Yes,
absolutely.
Comment on that, too? Yeah. I think when the medicine is working, you look at the world as if you're always going to be on. They use the term on, that it's always going to be working and things don't seem difficult. When the medicine is run out, like at night and when you wake up at night or in the morning, then it's as if you're going to be in that state all the time. That's kind of the way you look at things. And I realize that now, so you adjust for that, but it's still there.
I'd love to bring in your doctor, too, and talk about the difference between the medicine and then going to the deep brain stimulation. Is it typical that the medicine just stops working or stops being as effective as the patient gets worse? And
yes. Well, unfortunately, what happens a lot of the time is that the patients lose the effectiveness that they once had with the medication called L-Dopa or Sinemet. And that's where I think deep brain stimulation can help. It is highly effective for patients who benefit from the L-Dopa. And in fact, one of the things that we look for when we evaluate a patient for this surgery is, do they get benefit from the L-Dopa, the dopamine? And as it turns out, if the patient meets all of the criteria for deep brain stimulation, then chances are very good, and this has been published now, very well documented, that the deep brain stimulation surgery will usually help that patient.
And let's talk about your personal experience then with the deep brain stimulation. You were awake through the surgery. How quickly did you see the changes? How big of a deal was it in your life?
Yeah, I was awake, except I took a nap in the middle. And Dr. Lee said, we'll wake you up when we need you. So
that's nice.
There was an immediate change. You get what's called the honeymoon effect. For the first day to several days, just the disturbance of the brain during the surgery causes an improvement. So I would have walked out of the hospital, but policies, you have to ride in a wheelchair.
You're feeling that good.
We went out to eat at a restaurant, and I could eat all the protein I wanted, and it didn't interfere with the medicine because I hadn't taken any medicine. The other thing it's really done, I'm still taking medicine, but I pretty much dropped a couple of the medicines, went back to the basic one, using about 40% as much as I used to. And what's really changed is when the medicine has run out or isn't working, that base level is so much higher with the DBS. I can dress myself when it's like that. I can walk fairly well, especially once I get going and if I'm in an open place. Crowds are kind of tough, like the state fair, when you can never take a full stride. and there's all people around you, you tend to get up on your tiptoes. And
State fair is hard for everyone.
Yeah.
And fun. I'd like to hear your impressions as the spouse living with the disease too. How big of a difference? It sounds like it was just really a huge breakthrough, but emotionally, what big of a deal was it?
Well, it is a big deal.
Yeah.
I guess the thing that I learned through it is, and this is still true, but less so than before, you really need to keep your expectations in check, because even now he's very affected by protein, and so if he eats a fair amount of protein, the meds back off, and that puts him then down to the DBS level and not, on. And so as far as planning anything, expecting he will do this, I can't do that, because you just never know for sure. It's unpredictable, so we just appreciate and celebrate the times that it's on and working well.
Thank you so much, Artis and Tim, for letting us into your lives and your story here. Dr. Lee.
Thank you.
Thanks. Now, the Skoglunds have not taken part in Parkinson's support groups, but many find such groups helpful. Jackie Hunt Christensen is one such person. She was diagnosed with Parkinson's when she was in her early 30s. She's now an advocate and is active in the Parkinson Association of Minnesota and the Parkinson's Action Network. She's also the author of several books. Thank you so much, Jackie. Let's talk about why you think support groups are the way to go.
Well, I think it's very easy, especially if you're diagnosed as a young person like I was, to feel very alone. And as the disease progresses, there's frustration, especially, I can't emphasize enough, for care partners. Groups can be so helpful. And for the people with Parkinson's, I think what we end up doing a lot of times is talking about medication and commiserating about symptoms. But I think for the spouses and the children, it's a place to vent. And there are even support groups for people like Tim and I who've had deep brain stimulation surgery, so we can continue to talk about how it is living after you've had the surgery for a while. And there's just many, many benefits to groups, whether you're a young person or someone who's had the disease in their 70s or 80s.
Tell me a little bit more of your perspective, because we've heard and talked mostly about people who are getting this disease in their 50s and 60s, but in your 30s, what was that like for you?
It was very frightening. I first noticed symptoms right when I went back to work after the birth of my second child. I was 32. It took a year and a half, and several neurologists, I think the third one finally diagnosed me, as Tim said, with here's a pill, if it works, this is.
Right, in a year and a half, so you were having symptoms for a year and a half before, probably because you were so young. Were people not thinking that was a direction to go on diagnosis?
I think it was part that I was a young person. I honestly think being a woman had a little bit to do with it. One of the neurologists told me to see a psychiatrist.
Oh.
So, but I do know a lot of younger patients who have said that they've had similar experiences, both men and women, with it taking a while to be diagnosed. I think because even a lot of physicians do still expect to see it only in older patients.
And again, this is a little more prevalent in men, so that might have been part of it too, not to be cruel to all physicians. But again, tell us a little bit about becoming an advocate too, because you could have been a spouse who became an advocate, but here you are a person who knows the disease very intimately. What is the importance of advocating from your perspective?
Well, I was an activist before, so for me it was a natural extension, but I feel like I need to try and do something, especially since I've had the deep brain stimulation surgery and I have had very good results. I feel like it's given me a second chance to go out and educate people about Parkinson's, especially policymakers, and talk to people in the community. I think educating people about how Parkinson's affects communications is really important to me.
And finally, tell us what your advice would be maybe if somebody is out there watching and listening to this and just got diagnosed or has a family member who's recently diagnosed. What would your advice be?
I would say look for a support group in your area. It can be very frightening to go the first time. Keep in mind, Parkinson's is different for everybody. So when people go to their first meeting, if you see someone who's moving around like a human slinky like I used to, or who's very stiff, don't assume that that's how you're going to end up. Just go and listen and learn and just make friends with people, because it's a lifelong disease and you'll need these relationships.
Thank you so much, Jackie, for your time and for your advocating. Well, the recent Frontline documentary on Parkinson's hinted at some of the next generation research on Parkinson's, including the work of Mayo Clinic physicians in Jacksonville, Florida. Here's a clip from the Frontline website about the Mayo work.
We may not know what causes Parkinson's in most cases, but the Mayo Clinic's Dr. Matt Farr thinks one factor has too often been ignored.
There's genetics in everything. You know, we're biological organisms. There has to be a genetic component to Parkinson's disease, just like anything else.
Yeah. Until recently, nobody thought genetics played much of a role in Parkinson's disease.
Well, actually, when I first started writing papers on Parkinson's disease and familial forms of Parkinson's disease, they would, the editors of the papers or the reviewers would send back the manuscripts to me and say, you can't say this. You can't say this isn't Parkinson's disease.
But in the past decade, researchers have been able to pinpoint a genetic factor in a small percentage of Parkinson's patients, a discovery that yields two key insights. First is early identification.
With genetic forms of Parkinson's disease, it allows us to identify key individuals, key families that are at risk of the condition. We can diagnose the disease much earlier. And one of the things about Parkinson's disease is by the time people start developing motor problems, they're already about 50% of the way through the disease course. The disease is quite far advanced by the time they get motor symptoms.
Throw stuff over to your right and then over to your left.
And if you're diagnosed before serious symptoms begin, you have the opportunity to utilize various neuroprotective strategies, from drugs to exercise. Second, identifying a genetic connection allows scientists to assess what's gone amiss inside the brain, right down to the molecular level.
The entire rationale of my lab is built around developing, understanding the molecular causes, understanding the pathways that they affect.
Looking for genetic clues to a disease is a bit like searching for the proverbial needle in a haystack composed of the 3 billion DNA base pairs that make up the human genome. But at position 6055, within a gene called LRRK2, Farr and his team, along with one at the National Institute of Health, found the genetic mutation that causes the most common genetic form of Parkinson's.
It's a G to an A change, and it encodes a change in the protein of a glycine to a serine.
And that little change from the G to the A, resulting in that little
that
hump,
is
that makes all the difference.
Yeah, that is the commonest genetic cause of Parkinson's disease. That is it. It's quite incredible, really, isn't it?
Farr uses an illustration of the faulty gene to compare the mutation to a broken molecular doorway.
It's the hinge of that door that's broken.
The hinge is broken in LRRK2, the door is always open, or is always ajar.
And the thought would be to create a drug that could close that door?
Actually fill the doorway. And that will be neuroprotective. That's the big hope.
So this is the sweet spot. I mean, this is the...
That's the druggable target.
Yeah.
We're going to spend the rest of our program looking at some of the next generation of research into Parkinson's disease. Again, Dr. Mayo is here, and he's a neurologist at Mayo Clinic, of course, and we introduce, once again, Dr. Paul Tuitt. He's the head of movement disorders at a clinic at the University of Minnesota. Dr. Kendall Lee is again joining us. He's a neurosurgeon at Mayo. And we'll be weaving Dave Iverson back into the conversation. Dave is the producer of the Frontline documentary, joining us on the phone from San Francisco. Dave, I think looking at that clip here, we saw that exercise is really something that we know you believe in. You've always been kind of an exercise fanatic. How big of a believer are you in exercise making a difference?
Well, I think the definitive science is probably not completely there yet, but at a certain point when you have a condition like Parkinson's, you're not so much looking for certitude as you're looking for hope. And exercise is something that allows you to be hopeful. It allows you to feel like there's something you can still do to be in charge of your own body. One of the things that happens, and you heard that from your earlier guests, from Tim and Art, is that you start feeling like you're not really in charge. You can't really plan for what you're going to do. And exercise is something that allows you to begin to feel like maybe you can do something that puts you back in charge of what's going on with your body. And the early research that's being done at places like the University of Pittsburgh, University of Maryland, and elsewhere seems to suggest that there are some positive effects from exercise, both in perhaps protecting the brain from getting Parkinson's, but be even more encouraging for someone like me and members of my family, may do something to slow the progression of the condition.
Okay, let's throw that question out to our physicians here. I noticed you were nodding, Dr. Tuitt. Yeah. How much of a believer are you in exercise mentally and physically?
Well, I believe exactly what Dave was saying. When I have patients come in, and Dave, I don't know if you've started on medications. You've mentioned your clip about resagiline, but I think the first thing I bring up in conversations is to patients who are just diagnosed is we're probably not going to start you on medication for a while, but the first thing I do is send them to our physical and speech therapist to introduce them to big and loud therapy, which is a therapy that's been proposed by Becky Farley at Arizona. And
what's big and loud therapy?
Talk louder than you would normally do, and patients with Parkinson's often are talking softer, and so it works on voice enunciation, and most speech-language pathologists that know something about Parkinson's are trained in techniques to do that. And then big therapy is making exaggerated movements, 120% of target, so that will help with arm swing. And these are sort of behavioral modification techniques, motor, muscle memory things you want the patients to do and work on. And it's something they can do. And working with a positive therapist or therapist, a team effort, you feel like you're making headway, and you are making headway.
Dr. Marginori?
Well, you know, exercise is like apple pie. You can't say anything bad about it, you know. And, of course, it's important for patients to exercise for all the reasons we've heard about, giving you a sense of control over your destiny, or a sense of hope that I can do something that makes a difference. I actually thought that the program, the Frontline program, was fantastic because it actually is starting to attach some science to things that we've known for a long time. We know that patients who exercise have better outlooks and in general do better than patients who don't. But we're starting to understand that there's a science, a biology to it. By exercising, maybe we're increasing growth hormones in the brain that are actually causing nerve cells to survive or to repair better. And I think that's very exciting. I think this research needs to be encouraged.
Does this also speak to Dr. Lee that the research is really ongoing and maybe still a little bit new in this, even though it's been going on for many decades?
Absolutely. Yeah. And in fact, my area, with regards to deep brain stimulation, this is now a very exciting area of research because we now know that the deep brain stimulation works, but how it works is still a mystery. And yet, what's happening now is that there are very exciting results coming out, both laboratories at Mayo Clinic as well as elsewhere around the world, that's showing that deep brain stimulation really appears to be modulating the brain. It's a neuromodulation where, just like the growth hormones or these chemicals that could be released in the case of exercise, may be similar with neuromodulation, where deep brain stimulation, neuromodulation, could be causing different type of chemicals to be released in the brain.
Wow.
And in fact, that's one area that we are very actively researching in the neuroengineering laboratory at Mayo Clinic.
So how much do we really know about the root cause?
I still want to follow up
Yeah,
on the
sure.
exercise because that's
Yeah.
an area of pet research that we've been doing. And based on the Pittsburgh piece, they had the monkeys on the treadmill. So one of the questions, I think, age-old questions, is if you develop Parkinson's, you usually get one side affected more than the other. So we did a study, and we had the patients kept their good arm restrained and forced them to use their more affected side. So it was built on sort of the basic science that was being done at Pittsburgh. And so and we didn't show a benefit in this case. It was a small study of 6 patients that did it in an open fashion. But the issue was, would you have some functional reorganization at the brain level? Would they have improved function? Because patients with Parkinson's tend to use their less affected side, and they start to switch tasks to that less affected side. So if their Parkinson's begin on the right side, they might start taking on tasks on the left side. And we don't know, should you force them to use the more affected side, or should they go, so that question really needs to be discerned. And that's back to the exercise project, is these studies that are going on, is can we retrain the brain that is having a degenerative process that's ongoing? And those are things that I think the Pittsburgh group will do, and it goes into what Dr. Lee was mentioning, is can you assemble new circuitry in the brain in terms of functional circuitry, either with neuronal hardwiring changes.
How about, again, taking this backwards to what we really know about the root cause? You mentioned earlier in the show that people used to assume this was environmental.
Sure.
Could some of it still be environmental? How much is genetic? How much do we know about what that mix might be?
Well, I think that the emperor's new coat of Parkinson's disease is you'll hear everyone in the academic field saying it's due to gene-environment interaction. Which are the genes and where's the environment? And really, there's very little evidence that genetic factors and environmental factors interact to cause Parkinson's, but we like to hear it. We want to believe it. But what do we know? We decided to take a different approach. We decided to be agnostic and to not make any assumptions. And the rare families that were being studied by my dear colleague and friend, Dr. Fair, in Jacksonville, they were giving us clues about exceptional cases of Parkinson's disease, but they weren't telling us why the vast majority of people with Parkinson's disease were developing this illness. So we decided to take an agnostic approach and to look at genetic variation across the whole genome in several hundred patients with Parkinson's and 700 controls. And the clues that we got from that study were amazing. Very much to our surprise, what we learned is that the root causes could date to the very first days of life after conception. How the brain is wired and how that brain wiring is repaired throughout life could be a vital piece of this puzzle that we've been completely ignoring and neglecting. It's a fascinating possibility that Parkinson's disease could have a developmental origin that begins in utero. And maybe we've been looking at the wrong end of the environmental spectrum. We've been studying all of the things that we're exposed to as adults in the environment. Maybe we need to look back to what was our mother exposed to.
Yep. And I want to get to Dave in just a minute, but quickly, Dr. Lee, you looked excited about this too.
Well, when Dr. Maraganore mentioned the circuitry, I think the main drug that we use for Parkinson's disease is working on the dopamine system, which is part of a neural circuit of the brain.
Which is there since birth, right?
Yes, exactly. Yeah. And that circuitry also appears to be how we are, as neurosurgeons, modulating with neuromodulation or deep brain stimulation. And so all of these pieces of puzzle are coming together so that I think the next 10 years in Parkinson's research will be very exciting.
We want to hear from Dave one more time before we run out of time. Dave, what are you excited about? What do you think the prognosis is? Wrap it up for us, please.
Well, I think there are just so many things that are out there. There's so many paths up the mountain. I think that DBS can be helpful for some. Genetics research is encouraging. There's lots of possibilities out there, and I think it's important to remember that while some studies, those at UCLA, Harvard, and elsewhere, have shown that there is this effect by way of environmental toxins, there's many, many things that we still need to figure out. But there's also so much reason to be hopeful about where this can go. And there are things that I believe that will happen that will help us slow down the progression of the disease. We may not just have to worry about that, that holy grail of the perfect cure. That may or may not come within my lifetime. But we will learn ways to slow the progression of the disease. And for someone like me, if you can put a hold on it, if you could keep me where I am right now, I'll take that.
And quick final word, Dr. How do you think the progression is going to be slowed, and what's the prognosis and the longevity for people?
I think we're about a year or two from seeing a dramatic new class of medications that are targeting specific disease processes, abnormal accumulations of proteins that we've known about for 10, 11 years now, drugs to reduce alpha-synuclein. And Dave, I think that we're going to surprise you. I think in your lifetime, I pray that in your lifetime we will have solutions. I think we're very close.
Thank you so much for that positive end note, doctors. And before we go tonight, we want to make sure that we give out one more time some places for you to go on the web to find answers about Parkinson's. The National Parkinson Foundation has a website, parkinson.org. The American Parkinson Disease Association is at apdaparkinson.org, and the Parkinson's Disease Foundation, their site is pdf.org. Now, we encourage you again to please get the help you need, and thank you so much for joining us this evening for our program. Good night.
Parkinson's in Minnesota is a co-production of Mayo Clinic and Twin Cities Public Television.